abdominal pressure, or chronic cough, or extremely constipated patients, and so on. Enlarged prostate, for example, that will be also an issue because of the straining that patients actually do every day to go to the bathroom and to have this, and then they will create these problems in the issue. So you can go from the very minimal representation of what a varicose vein is, which is a reticular or a spider vein, something like that. Which is, and who hasn't seen those? I mean, those are very frequent. Everybody may have one or two, and sometimes they bother you. In young people, actually, that have not passed through the menopause, they complain about some pain on these little veins when they have the menstrual period, and it becomes very symptomatic. Sometimes there is some itching, there is some swelling sometimes, and so forth. Sometimes can be so prominent that you can get some bleeding also from those. But then you have the more severe cases in which you have the bulging of the legs, the bulging of the veins on the legs in several parts of the legs. And those are the ones that bother the most. Even though some patients may have this, and they don't complain until they start to develop more swelling because of the stagnant blood that you have in your leg that doesn't circulate that well, and then you develop some transudate that will give you some swelling of the extremity. Again, those are a little bit more severe. You can see those varicose veins more prominent. Okay, this is in the calf. And the problem continues, and it becomes a little bit worse and worse and worse until you can develop areas that are very, very enlarged. Patients sometimes are being stopped in the airport. They think that they are carrying something. It's just the varicose veins, but they are thinking that they are carrying something when they are being checked. The end stage problem is that you will continue to develop pigmentation of your skin. It's going to be darker, especially in the area of the ankle and the distal third of the leg. But then, when the swelling, the pigmentation, and the thinning of your skin becomes more accentuated, what you're going to have is a problem with a venous ulcer, and that's a problem. That is a big problem. This is something that is created just by varicose veins, as you can see. That's the only problem. There are no blood clots. There is absolutely no other thing. Those are just varicose veins creating this leg with an ulcer. And that's a big problem because when you have an ulcer that is that has an etiology of being venous, you have to heal first or get rid of the problem that is created. You have to get rid of the problem with your varicose veins or the venous insufficiency. If you don't do that, that ulcer is going to procrastinate. And for a long time, a very long time. I have seen patients that come with these problems 33 years, 20 years with this problem. And it's very difficult for them to know what exactly goes on, and this is very painful. This is something that actually is telling you what to do every day. You don't have any way of knowing what you're going to do the next day because everything is going to depend on the pain or the swelling or anything that you have in your leg. So you can go with a lot of doctors here, and in my experience, all these patients, they are here, and then they go to Mexico, and then they come here, and then they're all over the place, and until really you have somebody that knows the pathophysiology of these problems, the treatment is not going to be just a simple ointment that is going to heal those patients. And you can have more problems with that, and those ulcers, and those problems, and the veins, and these are just pure venous problems. They don't have any other thing. They don't have diabetes, they don't have any high blood pressure or anything, but they have an ulcer.
Could they have prevented that before you got to an ulcer?
Yes, but it's very difficult because people, you can get used to the pain. Right? All of a sudden, you live with the pain, and all of a sudden that forms part of your life, and then it gets worse and worse and worse until you develop an ulcer. Okay, so people get used to the pain. It's very, very common. Okay. All of a sudden, you don't even know that you have pain, but you have it, and you are just living with it. especially in very old people. You know, those are the patients that can get you so easily to the pain. Now, what do? We have a patient that has either just a small spiral reticular vein that wants to get rid of, like the first ones that we saw, or a patient that has an ulcer, or a patient that has those bulging veins. What do we do for that? Well, the first test that we do is a venous Doppler, and it's just an ultrasound, okay, nothing major. An ultrasound that will let us know where those defective veins are. An ultrasound that will let us know where the superficial and the deep system, what is the status of those, okay? How the superficial and the deep system. And once that we get a venous Doppler, which is an ultrasound done by a technician and subsequently read by a physician, then we can actually start treating these problems. The ultrasound is very simple. It usually takes about 10 minutes or so just to really look at all the function that you have on your veins. You can see the flow. If the flow goes down every time that you cough or get up from the table, then that's something that we call reflux. And based on the reflux that you have in your veins, meaning the amount of blood that goes down every time that you stand up, that's the degree of insufficiency that we will think that we are going to have. That's why we do the Doppler. And it's again just a measurement, and then once that we categorize that measurement, then we can go with you and tell you, okay, your veins are like this, and you have this problem, or you don't have any problems, or you will have with this type of treatment, or you will have with this other type of treatment. So, what do? Well, it's a little bit of convoluted treatment, okay, if you want, but these treatments are evolving in time. 20 years ago, the only treatment that we used to have was to go there, and those veins that were defective that we could see on the ultrasound, or sometimes without even knowing that there was an ultrasound, we would go there and we would remove those veins. That was the only thing that was there, and that's the surgery that is called ligation and stripping. Okay? Maybe some people have heard about it, but the ligation and stripping surgery is a surgery that is barely done nowadays. I was doing those about 20 years ago, and it was to go to the hospital, to be admitted, to stay there for 2 or 3 days after the surgery. We used to go and blindly find out where those veins were, and then put a wire, and then tie them up to the wire, and then pull them out. And the patient was under anesthesia. There was some bleedings, and then it was very traumatic. Really, it was actually very barbaric. I never did like it at all. That surgery, it was not really a surgery that I was a fan of. But the first thing that somebody asked, okay, could that be prevented? The first thing that we do before the surgery is to try to go with the most conservative treatment, which is just elastic stockings. So there is no magic bullet here. Elastic stockings is the only thing that actually works to prevent the varicose veins. And there are no pills or something that are going to prevent you. Elastic stockings. Why? Because it will compress your veins when they are dilated, and at the same time will hold on the valves that will make them a little bit more sufficient, more functional. So that's the first step to prevent it. Okay, but we use them for treatment as well. We do some in the most incipient or early cases, like you saw. We do some laser and we do some injections to remove those little spider veins of the reticular veins. But this is something that we do in the office. It's very simple. It's not a big deal. Okay, it doesn't go away from one day to another, but it goes away. It usually takes about 6 weeks or so, to get rid of these veins in several sessions.
Do they reoccur, doctor?
They can recur if you don't take care of the major problem, and the major problem are those veins that are actually producing those that you can see. That's why we do the Doppler, and the Doppler or the ultrasound will let us know if there is a defective vein that needs to be actually taken care of. So how do we take care of those? Well, we go with the ultrasound ourselves, after we saw the Doppler, the function of each vein on your leg, and then we decide which veins we are going to have to get rid of so that you don't have that bulging area that you have on your leg or that problem that you develop. And what we do is that instead of removing it with the stripping surgery that we used to do, that was very traumatic, what we do is we put a laser inside that vein, we give a little bit of local anesthesia, it's done in the office, and then you go. That's it. You don't have anything else to do. Usually people just complain, a little bit of swelling, minimal, then the really pain medication that they need to take for something like this is minimal. The procedure takes about 30 minutes and we're done with that, okay? And so on and so forth. So depending on how many veins you have defective on your leg, that's the number of the procedures that we may need to do. Usually no more than 2 per leg. And again, we put a catheter inside your leg, we give a little bit of anesthesia, and then we just, with thermal ablation, meaning by heating up that vein, we destroy that, the vein is going to heal inside your body, you will have only a tiny little incision in your leg, that is where the catheter, this catheter is going. That's it. There's nothing else. We don't really do anything else. We don't try to give you general anesthesia, put you in the hospital, admit you to the 2 or 3 days or anything. You're going to go in walking and you're going to get out walking.
Do you finish in one session? Like the whole, like you have a lot? Or
no, one vein at a time. So if you need, as I said, maximum 2 per leg is usually then it's going to be every week or something like that, 1 day. And we use several techniques. This is a laser that is inside the vein that goes in the patient. You can see the light under the skin. Or we use glue, and this is the latest treatment that we have on the armamentarium for chronic venous insufficiency or varicose veins. And it's a very ingenious, actually, way of treating this. And this is how it evolved. We start with laser. We put the laser inside the vein, we heat the vein up, and then we basically burn the vein from the inside out. We give you anesthesia, and you're fine. Okay. Then we said, well, maybe laser is not as comfortable as the radio frequency. The radio frequency is with electrical energy. It's like those machines that you use to cauterize in the operating room and the bleeding vessels, but this is a big catheter, so we cauterize that big vein. Pretty good, much better than the laser actually, because the patient was very comfortable. Okay, less problems, less complaints, less pain, less everything. Okay, but for that we need to give some local anesthesia, and the patient may say, well, I don't like the little needles. So then we just came up with the Venosil, which is glue that we don't need to give anything except just a tiny bit of local anesthesia where the needle is going to go. We put the glue inside the vein and we finish the test. And the results are exactly the same for the 3 of them, but more comfort for the glue, for example, which is the one that is coming along right now. Okay, and eventually this is going to be more standard of care than the other ones. And again, we just deliver glue inside the vein, and that vein is now going to be closed forever. Then it's going to heal, and that's it. So you get rid of the source of insufficiency, that vein that was refluxing blood going down to your leg and distending the rest of the legs. And again, this is what we want to achieve: a closure of those veins that are defective, that are just delaying the circulation of your blood. And what is going to happen with that circulation, meaning that blood that was going through there, is going to go through another more appropriate veins in your leg. Remember, the most important system is the deep system. The superficial system you can dispose of. Okay? And again, it's the same thing. So we try to take care of that vein that is giving you all these varicose veins around the leg. Such a way that once that we take care of that, the results after removing the vein completely and so forth is something like that. And you can see that there's a big difference because there are patients that are having very, very prominent veins. Or you can have these problems in which the problems with the varicose veins, became much more of a problem not just because you can see the origin, but also because you develop several ulcers on your legs. Same issue with this one.
Doctor, is it more common in females than it is in males, or is it just about
Yeah,
the same?
by far. And everything is because hormonal changes, estrogen cycling may increase this possibility, and also pregnancy. Okay. But when we see guys coming in, they are twice as sick. We don't take care of themselves. And the end stage of the venous insufficiency is the ulcer. The ulcer is a big problem. It's very chronic. If it is not treated appropriately, it goes with issues that are very, very sophisticated. And really, it goes from a lot of redness and problems with poorly healing ulcers to all the way a complete ulceration of the leg. And patients are very, very poorly satisfied with this because this is a problem that lingers forever if it is not treated appropriately. And appropriately means to treat the underlying problem. Okay. Let me see, because I think that I got this a little bit mixed up at the end, and I don't want to just stay. I don't want to start looking at these ulcers. Anyway, and again, we do the surgical treatment, which is the endo laser or radio frequency or the glue activation for these ulcers. Very important to know that by doing these treatments that seem to be very simple, actually, we can heal more than 60% of those ulcers in the lapse of 4 to 6 weeks. And the other 40% may require a second treatment. So 60% is a lot for an ulcer that has been lingering there for years. And again, and so the ulcers is the end stage disease of the venous insufficiency, and on the after